Our next speaker is Professor George Kundus, who I worked with many moons ago under Professor Bourne, and he's gone on to bigger and better things. And he's a professor of obstetrics and gynecology at the Sydney Medical School in Nepeans and specializes in gynecological ultrasound and advanced endosurgery. He's head up the first and only acute gynecology unit in Australia and is also responsible for the one-stop based diagnostic clinics where we review abnormal bleeding, chronic pelvic pain, including endometriosis. And he also does advanced endosurgery procedures for women who need intervention for pelvic masses and adnexal pathology and severe endometriosis or even hysterectomy. Now, this talk is really important about pelvic pain and including the diagnosis of endometriosis, which is often missed because it's difficult to see these nodules on scan if you don't really know what you're looking for. And it's absolutely key. So many people have a so-called normal scan, but when scanned by somebody like Professor Kundus, we see the nodules. So it's crucial. Thank you very much for making the time all the way from Australia. George, over to you.
The non-invasive diagnosis of endometriosis has evolved tremendously over the last 15 to 20 years. And I think the place of endometriosis imaging in the world of gynae ultrasound is pretty much front and center as one of the most progressively changing and technologically advancing ways in which we use ultrasound. If we look at the way in which we've traditionally viewed the diagnosis of endometriosis, if we go back to the 2008 ESHRA guidelines, and we can see that the traditional gold standard, and this is something that we were all taught as medical students, for those of us who are old enough, and even more recently during our training, that the gold standard for the diagnosis of endometriosis was an invasive test, which was a laparoscopy. And that was really born out of the fact that we only really had access to basic pelvic ultrasound scan. So what does that mean? That means that we perform an ultrasound scan, we look at the uterus and the ovaries. And so with that conventional assessment, we can visualize the presence or absence of hard markers such as an endometrioma or a hydrosalpinx. And the problem with that is if the pelvis is deemed to have no hard markers present, then we'll report that pelvis as being normal. And we've all experienced and encountered scenarios when we've taken someone to theatre with a normal pelvic ultrasound scan, and that patient subsequently gone on to have endometriosis and sometimes even severe forms of the disease. So the traditional basic pelvic ultrasound indeed has limited diagnostic capabilities. And the consequences of that are, for those patients who go to theatre, particularly in a unit like mine where the rates of high stage disease are around 20 to 25%, there's no detailed surgical planning. The gynecologist has a unidisciplinary approach to the way in which they approach the pelvis. And if they are then for the first time faced with a scenario where there's obliteration of the pouch of Douglas, potentially underlying bowel endometriosis, then those patients have an unplanned intraoperative colorectal consultation. And under those circumstances, the patient's not bowel prepped, the colorectal surgeon hasn't met the patient's not appropriately consented. And so, therefore, the ability to cytoreduce the disease has been compromised. These patients potentially have higher rates of complication because there's unforeseen high-stage endometriosis. And often what happens is the surgery is abandoned, and in these cases, these individuals go on to have two-step laparoscopic approach for their high-stage disease. So if you move forward into the third decade now of the 21st century, and we see now that from 2022, ESHRA has changed their guidelines with now stating that laparoscopy is no longer the gold standard for the diagnosis of endometriosis unless imaging, either in the form of ultrasound or MRI itself, is negative. So this is a huge change in the space of 14 years. So we now have a non-invasive diagnostic tool for the diagnosis of endometriosis. We have the ability to see not only the hard markers such as ovarian endometriomas and also hydrosalpinges, but also now we can visualize and assess for the presence of adhesions within the pelvis, looking at ovarian mobility, the status of the pouch of Douglas, and also we can assess the pelvis compartmentally to look for signs of deep endometriosis. And even more recently, work that's come out of my unit in 2021, we published the first paper on the use of sonopedography for the diagnosis of superficial endometriosis. So our ability now to close the gap between a traditional pelvic scan and maximizing our ability to get every ounce of information from the ultrasound we perform has been just been transformational in the management of patients. And I think that this non-invasive diagnostic tool will also, in time, have influenced the unacceptable diagnostic delay from first presentation to diagnosis, which I think is actually potentially really, really important for our patients. And the reason now that we can potentially improve our ability to predict disease pre-surgically is we've now got a roadmap, which is the IDEA consensus, and this gives us a step-by-step approach to the way in which we should assess the pelvis when performing an ultrasound and assessing a woman with chronic pelvic pain, particularly under the circumstance that we think that they may well have underlying endometriosis. And as a result, a consequence of that now is that we indeed, in those patients that are symptomatic with scheduled for surgery, we've got detailed surgical planning. We now can invoke a multidisciplinary approach, which is in keeping with the World Endometriosis Society guidelines and also the NICE guidelines. In those patients that have got high-stage bowel disease or even urological disease, we can arrange a preoperative colorectal or urological consultation. Patients are bowel prepped appropriately before the surgery. The consent is so the surgical team has an understanding of not only just the location, extent of the disease, but also whether there's actually involvement of non-reproductive organs. And so the consent can be specific, which is important also, I think, for managing patient expectations. And because we now have the ability using ultrasound to get the right team at the surgical table for the first surgery, we're going to maximize side reduction and also reduce or minimize that load of disease at the first surgery. Because everyone knows their role in the surgery, there's a lower complication rate, and in those patients that's a high-stage disease, because we're having that joint approach, it's a one-step laparoscopy for those individuals with significant endometriosis. So there's been a huge shift in the way in which we diagnose endometriosis, but also plan surgery for these particularly complex cases. I'm going to go through the different potential benefits of non-invasive diagnosis using ultrasound preoperatively, particularly when thinking about planning surgery for patients with endometriosis. And I'm going to look at our ability to assess the status on ultrasound preoperatively of the uterus, status of the urinary tract, the status of the pelvic sidewall, pouch of Douglas, and also the rectosigmoid. So as part of the IDEA consensus approach, step one is to assess the ovaries and the uterus itself. And a really important aspect of assessing the uterus in patients with chronic pelvic pain, potentially dysmenorrhea, heavy menstrual bleeding, is to look for the potential presence or absence of adenomyosis in accordance with the MUSA consensus. And so in the first two slides on the left, these still images we can see, you get grayscale representation of a case with adenomyosis, bulky uterus with linear striations, asymmetry of the endometrium, or loss of the junctional zone, potentially even some small subendometrial cysts present as well. And in the second slide, we can see that classic diffuse linear striations throughout the posterior myometrium. So having an understanding of the presence of endometriosis, adenomyosis is important because particularly in those patients where we're considering performing a concurrent hysterectomy in patients that have got endometriosis, we want to have a fairly clear understanding of what's the likelihood. Obviously, we'll improve and we'll cure any heavy menstrual bleeding, but how will we be able to manage the expectations when it comes to improving or potentially having a positive impact on someone's chronic pelvic pain? We can also assess the volume of the uterus, and that's really important when it comes to deciding whether there's a likelihood or not, or whether we need to morcellate the uterus at the time of hysterectomy. And in the far right-hand side, when we look at the position of the uterus, it's really important to be really cognizant. So when we see a uterus that's anteverted and retroflexed in the far right-hand video, these uteri are drawn posteriorly towards the disease in the posterior compartment. And so this is a really strong marker for the presence of there being rectouterine adhesions and potentially also underlying rectal disease itself. So there's a lot of information we can glean when we come to assessing the uterus pre-surgery in patients that are undergoing endometriosis and also potentially hysterectomy at the same time. When it comes to the urinary tract, we know that it's possible to have a clear assessment of bladder for bladder endometriosis. Now, bladder deep endometriosis is not very common even with patients with deep endometriosis, but we can see quite nicely in this 3D rendered image on the left-hand side, and thanks to my previous fellow, Jose, for producing these images for me. And we can see that there's a really beautiful image of a bladder dome, deep endometriotic lesion. And then during the straight sticks laparoscopic approach, we can see that this is being removed using cold cut scissors and then the bladder itself is closed in 2 layers. So knowing ahead of the time the status of the bladder lesion, its non-proximity to the ureteric orifice is also really important when it comes to planning the surgery. And the bladder itself is a very resilient organ, so it's possible to get really good results when performing bladder surgery. So this will be done with the urologist in tow. As part of the assessment, when we're thinking about looking at the urinary tract, it's absolutely critical that we assess the ureters themselves. And it's possible, in my situation, I reverse and invert the image. And so we're now looking at a longitudinal sagittal view of the distal third of the ureter. And it's possible using color Doppler to actually appreciate the jet itself. And it's more important actually not just to look at the distal third of the ureter, because even though you may on occasions have ureteric obstruction distally, it's also really important to follow the ureter cephalically, particularly as it traverses or it's in apposition to the pelvic sidewall, because there's often a situation where you may get normal distal third of the ureter, but potentially the middle third of the ureter may indeed have a degree of retroperitoneal fibrosis, obstruction, and hydroureter. So assessing the ureter is really an important aspect of the surgery, because again, if there's any potential compromise of the ureter itself, then again, these patients need to see a urologist preoperatively, potentially assess their renal function, and also do a contrast MRI to look at the actual status of the urinary tract itself. In the next slide, we can see really quite nicely this concept of bringing together ultrasound and also surgery under the same banner in a case where a patient's got quite a decent size uterosacral endometriotic lesion that's extending into the parametrium, and that's compressing the ureter. So we've got hydroureter, and the distal third of the ureter itself is dilated. And when we review this patient saw the urologist preoperatively. We knew ahead of time that this patient had a ureteric lesion that was compressing the distal ureter with an associated hydroureter. I'll run that video again. And in the matching laparoscopic video on the right-hand side, we can see the presence of the DE nodule of the uterosacral ligaments extending into the parametrium. We can see the outline of the ureter itself, where there's compression, external compression of that distal third of the ureter. And we can also see that the ureter proximal to that is dilated itself. So this patient saw the urologist, and we planned to do a ureteric reimplantation based on the fact that there was clear outflow obstruction to the urinary tract on the left-hand side. So a great deal of knowledge being gleaned again from the ultrasound itself. Thanks to Matthew, who was also a fellow of mine who's now back in Canada. And it's also important that we, having looked at the uterus and ovaries, but even if there's an endometrioma present or not, we always look at and assess ovarian mobility. So it's important to look at the mobility of the ovary up against the pelvic sidewall laterally, look at the ovarian mobility intramedially against the uterosacral ligament, and also the ovarian mobility when it comes to its relationship with the uterus medially. And we know in those individuals that have an ovary that's fixed either to the uterosacral ligament or the pelvic sidewall, that these individuals are probably more likely to need to have ureterolysis at the time of their surgery. And we can see again this concept of matching the ultrasound video to the laparoscopic view, and again bringing those skills together in the same unit. So having the ability not only to diagnose the endometriosis, but then to perform the surgical intervention and perform complex surgery, dissecting out the ureter, lateralizing the ureter, dissecting the ureter away from the uterosacral ligament itself, and then working towards the origin of the uterosacral ligament before excising the disease safely. And we can see that there's an endometrioma in close proximity to that uterosacral nodule, and that pops just at the time of the actual ovary being mobilized itself. So assessing the pelvic sidewall is really important. And even work that we've done, Shannon Reed's team have done the ovarian sliding sign, and that's potentially been a predictor for the need to ureterolysis. And my team published in the JMIG in 2022, we developed a logistic regression model to predict the need for ureterolysis in patients undergoing endometriosis surgery. And the prognostic variables that were important was the presence of ovarian immobility, rectouterine adhesions, potential rectal nodule, and dyschezia. So it is possible to potentially predict ureterolysis. And one of the other benefits, apart from being able to visualize, I think, the status of the pelvis, have an understanding of the stage of disease, where the endometriosis is anatomically. But I think more importantly, the translational impact of the ultrasound is, I think, it enables the surgical team to choose the right surgical team. So if a patient is under your care and they require ureterolysis or they require urological colorectal input, and you are a generalist and you haven't got the confidence or the skills to manage such patients, then ultrasound, I think, also can be a game changer. And it allows the surgical team to triage. It can be the general practitioner in primary healthcare. It can allow the general practitioner to refer their patients to the right surgical team from the outset. And this is, I think, the best way to get the best possible surgical outcomes. Now, it's also important that ultrasound gives us the ability to assess the status of the pouch of Douglas. And we know from experience also those individuals that have got obliteration of the pouch of Douglas, and we can see a laparoscopic view there with partial obliteration of the pouch of Douglas, the rectum adherent to the posterior uterine fundus. And we know that patients that have rectouterine adhesions are 3 to 4 times more likely to have an underlying rectal endometriotic lesion. In those patients that have got pouch of Douglas obliteration, whether it be partial or complete, the surgical team needs to have obviously great experience, but also a huge understanding of anatomy, has the ability to dissect out the ureters, mobilize the tissues from lateral to medial, starting in the normal avascular spaces, opening the pararectal spaces, the rectovaginal space, and then finally cleaving the rectum off of the back of the uterus before then handing over to the colorectal team to complete the surgery. So the status of the pouch of Douglas is really important. And there's been a significant number of publications in relation to this, the first being Shannon Reed's in 2013, where she looked at 100 cases prospectively of individuals that had signs and symptoms suggestive of endometriosis. And within that cohort, 30 patients had a negative sliding sign, and they were predicted to have an obliterated pouch, and of those 18 had underlying rectal disease, and of the 70 cases that had a positive sliding sign, as demonstrated here in matching laparoscopic and ultrasound videos, and those individuals that had a positive sliding sign and the pouch was predicted to be non-obliterated, only 1 out of those 70 cases went on to have rectal endometriosis at the time of surgery. So the sliding sign, which is also step 3 of the IDEA consensus statement, is a really important aspect of assessing and triaging the likelihood of difficult surgery. And again, that empowers the surgical team to know whether they themselves are the right team to manage this case, or whether they need to then refer on to an advanced endoscopic team. They may themselves be an advanced endoscopic team, and therefore they would keep such patients. So the status of the pouch of Douglas in the context of being a positive sliding sign is demonstrated here in the 2 left-hand videos. And in the next slide, we've got matching both ultrasound and laparoscopic videos from the same patient. We can see quite nicely. In contrast, we've got a negative sliding sign on the ultrasound on the left-hand side. So the uterus and the bowel and that lesion within the torus uterus are essentially fixed together. So there's no sliding sign whatsoever. So we've got a negative sliding sign in that video on ultrasound. And so under those circumstances, we predict that the pouch of Douglas would be obliterated at the time of surgery. And indeed, when we go to the matching video, we can see quite clearly that there is obliteration of the pouch of Douglas with significant rectouterine adhesions. So again, ultrasound really helpful in determining the likelihood of high-stage disease or otherwise. And remember, in tertiary units, the presence of pouch of Douglas obliteration is between 20 and 25%. So it's a significant burden within such high-risk populations. And finally, one of the most, I think, important aspects when it comes to the use of ultrasound is its ability to look at the status of the rectosigmoid. And that's important when it comes to planning surgery, because we can look at the size of the rectal lesion itself, we can look at the depth of penetration, the distance of the rectal lesion to the anal verge, and also whether the lesion is a unifocal lesion or whether there's the presence of multifocal lesions, so the presence of one or more deep endometriotic lesions within the same segment of bowel, as opposed to multicentric lesions where you've got deep endometriotic lesions in separate segments. So, for example, one in the cecum and one in the rectum itself. And the size of the lesion is important because we know that lesions that are more than 3 centimeters are less likely to respond to a limited rectal resection, and these patients more often than not need to undergo a segmental resection. There's good data out of Huddless group to demonstrate a correlation between depth of penetration and also distance from the anal verge. And they're also important when it comes to planning surgery. The vast majority of rectal lesions are extramucosal, and also the vast majority of rectal lesions are either at or above the level of the cervix. So that means that there tends to be at least 8 centimeters clearance from the anal verge. And that's important also when it comes to planning surgery, because these patients, as a rule, do not need to be defunctioned. The literature states that up to 30% of patients are undergoing defunctioning ileostomies. I think that's a procedure that needs to be obviously performed at the time of a potential rectal leak or an anastomotic leak after bowel surgery in relation to endometriosis, but I don't think it's necessarily indicated to perform a defunctioning ileostomy in patients where it's possible to preserve the inferior mesenteric artery. So ultrasound is really important when it comes to assessing the rectum itself. And we can see here, this is an example on the left side. And again, as a surgeon sonologist, we've got access to both the ultrasonographic video on the left-hand side. I think we can see quite clearly that coming into view now is a large 4.5 centimeter deep endometriotic lesion of the rectum itself. And so this patient, having seen the bowel team, we planned to do a joint segmental resection on this individual. And in the matching video on the right-hand side of the same patient, we can see that indeed, at the time of surgery, at the start of surgery, the uterus was anteverted and retroflexed, complete obliteration of the pouch of Douglas. We can't see the right ovary whatsoever, even though the left ovary is visible, so it's pretty fixed. And in the inferior image and video on the right side, we can see at the end of the surgery, this patient, who also had a vaginal extension, she had a colpotomy performed as well as a segmental resection with complete restoration of her anatomy. So now the rectum is completely free. Pouch of Douglas is being restored, and we can now see normal tissue below the levels of the uterosacral ligament itself. So knowing the size of the lesion preoperatively is absolutely critical when it comes to planning surgery for these patients and then being able to take advantage of there being a multidisciplinary team approach. Whenever you see one rectal lesion, it's also really important to look cephalic to that lesion. And here's an example here on the top slide. On the left-hand side is a large 3.5 to 4 centimeter rectal lesion. And in the video on the left lower side, we can see that there is an upper rectal lesion annotated as upper rectal endo 2. So we've got two lesions, two deep lesions within the same segment of bowel. So this is multifocal rectal disease. And again, we've got matching ultrasound and laparoscopic videos in this case, because obviously we as the team are the team that performs the diagnostics as well as the intervention itself. So we have access to both ultrasound and also surgery. And so when we see multifocal rectal disease, it's really important to measure the total length of the bowel that's affected. So measure from the most inferior aspect of the inferior lesion all the way to the most superior aspect of the superior lesion, the segment of the bowel that's affected. And we also need to demonstrate, and there's a bottom right-hand side, an annotation from the original idea consensus paper where we measure the distance from the most inferior aspect of the lower lesion, the caudal lesion, to the anal verge. And that's also really important when it comes to planning surgery. And remember, most lesions are high rectal lesions, and so these patients tend not to require a defunctioning ileostomy. And I think one of the great benefits of ultrasound also is because we've scanned this patient preoperatively, it gives accountability for the surgical team. So you know what's there, you know what's driving the rectouterine adhesions in the laparoscopic video on the right-hand side. You know that there's multifocal rectal disease, and you know that utilizing the colorectal team pre-surgically, having full bowel prep, consenting the patient appropriately is really critical to managing the expectations of the patient, to, I think, potentially also improving the outcomes for these patients as well. So there's a very systematic approach to these patients, both preoperatively, intraoperatively, and postoperatively when it comes to managing our patients with high-stage bowel disease in our units. And again, here's another example. Again, on the left-hand side, we've got the ultrasonographic video, and we can see that there's two rectal lesions, two deep endometriotic lesions in the same segment of the bowel rectum. Right-hand side of the matching laparoscopic video, you can see that there's complete obliteration of the pouch. There's a vesicular-like endometriosis over the surface of the actual uterus itself, and there's complete loss of normal anatomy. So this patient indeed does require not just significant planning, but also a really systematic approach when it comes to normalizing the anatomy at the start of the surgery. And the normalization of the anatomy itself, in a case like this, could take an hour, hour and a half before we then proceed on to excising the endometriosis itself. So knowing about the status of the pouch of Douglas, knowing about whether the anatomy is preserved or whether the anatomy is distorted, is really important when it comes to potentially planning surgery, but also quantitating risk in these patients. So ultrasound preoperatively from someone that performs ultrasound and also someone that performs high-level laparoscopic and robotic surgery, for me, is absolutely critical when it comes to planning surgery, because we can assess and understand the size of the uterus, whether the uterus has adenomyosis. We can also understand whether the uterus itself is anteverted, retroflexed, and fixed to potential posterior compartment disease. we have an opportunity preoperatively to view the anterior and posterior compartments. And in the presence of disease in either compartment, we can then call on either the urologist or the colorectal team, respectively. We can assess the status of the pelvic sidewall, which is important when it comes to triaging patients to the likelihood of requiring ureterolysis. And also importantly, we can assess the status of the pouch of Douglas. Again, because we know in patients that have got endometriosis with normal anatomy, that's a very different surgical challenge to those individuals that have endometriosis with complete distortion of their anatomy and fixation of the pelvis. And I think by having an understanding of not only the ability of ultrasound to diagnose endometriosis, to determine whether someone has low or high stage disease, and importantly, to clearly delineate whether structures such as the urinary tract or the gut are affected, I think then we can improve our ability to preoperatively have an MDT or a multidisciplinary approach to these cases. I think we can then maximize our ability to reduce the load of disease at primary surgery. We have an ability also, I think, to have a specific consent based upon the size of the lesion, the number of lesions, the location of the lesions, the distance from the anal verge. And I think that consent is really important when it comes to the patient and their family having a clear understanding of the complexity of the surgery, but also the potential for complications. And I think by utilizing ultrasound preoperatively, I think we can then in turn get the best outcomes for our patients and mitigate the risks and complications that are associated with really complex disease and potentially complex surgery.
George, as ever, thanks for a great talk. I think these lectures where you have the surgical position and the ultrasound is critical to understanding, particularly what's happening with endo. I'm sure you'll agree. And I guess that comes down to my question about learning. I think it's very hard to learn this unless you have the surgical correlate. I don't know how you feel about that. So that's one question I'd like you to just to address. But for many people, and we heard Francesca Morrow speak earlier about understanding the anatomy, who are starting to think about evaluating patients with endo, what's the most simple kind of screening approach? Would it be like do the sliding sign and look in the anterior and posterior compartment, check the ureters? Because I always found that the more lateral assessment was perhaps more difficult to learn. How did you start, as it were? Because maybe it's a bit overwhelming for some people.
I think to the first point, I think you're right. I think that if you have, and this is something that we even talked about when I worked with you, we're talking over 20 years ago, when we were looking at ovaries and adnexal pathology, and then we would take those patients to theatre. So you had that immediate feedback loop that I think for most sonographers or sonologists who are purists don't necessarily have access to. So I don't know definitively that shortens the learning curve, but it stands to reason that would be a nice way to validate very quickly if what you see is indeed what's there. So I think for those in the audience this afternoon, this evening, who have access to ultrasound, who perform ultrasound, if they themselves are surgeons, I think that's a great advantage, or otherwise they should definitely make sure that they work closely with their gynecological surgical teams to ensure that what they're seeing and what they describe on ultrasound is indeed the case, and go to theatre and get to see what's actually, seen down the laparoscope or seen at an open procedure or otherwise. In relation to starting out, I think you're right. I think that there's no doubt that I think if you start midline posteriorly, I think you're more likely to gain confidence. For the most part, when it comes to assessing the sliding midline, I think as you become more advanced and more sophisticated, you can look at the level of the pouch of Douglas obliteration. You can determine which sides or otherwise are affected. And I think you're right, as you tend to move laterally towards uterosacral ligaments, ureters, pelvic sidewalls, then I think the degree of difficulty does increase.
Okay. George, I'm going to have to be a bit boring because we're really tight for time this morning. You look as if you're on holiday or something. You've got your T-shirt on. If you tell me it's like 28 degrees in Sydney, I'm sitting here, it's just with a wind chill about -2. And I hate you. I'm sorry, just going to let this know. I'm going to let the world know the animosity is flowing out of me as we speak. We're going to have to move on. It's fantastic. Thanks so much for taking part, George.
Thanks, Tom. Take care.
See you soon, mate. All right. Thanks so much.